Dr. Yahya Ithawi. I'm a neonatologist, and this is the fourth session of a series of 4 sessions about neonatal resuscitations. I hope you watched the previous one, and today we'll complete the full resuscitation series. So we ended up with talking about medications in the last sessions, and this is a table showing important medications and tools that we are using in resuscitation. We can see here the epinephrine, which is 1 in 10 or 0.1 milligram per mil, and this is the dose required IV and through endotracheal tube, and the gassing volume with the weight and how we should give it. And the indication usually is to support the heart after CPR. Also the volume expander and the naloxone that we rarely use for these days, and dopamine as inotropes for hypotension, and also the dose of cardioversion, especially with the SVT and the ATT tube, and the size of the ATT tube and the laryngoscope. To give the medication in neonates after birth, we have very easy, accessible IV access, which is the umbilical vein. It can be done rapidly, and it can be done in aseptic technique. Now, for suitable standard situations, we can advance the catheter down to the inferior vena cava up to sometime even 12 centimeter. And because it's a matter of luck, 60 to 70% of neonates can be catheterized in the IVC, while the others can lodge somewhere else. And it might be undesirable and dangerous locations such as hepatic portal or pulmonary vein. For that reason, in emergency situations, we only advance the catheter for about 2 to 3 centimeter length is give access to flushing bag of blood, and since the blood can flush bag, that means we are central and we can give the medication. And in this position, usually it's just below the ductus venosus. It's important to flush the medication to make sure that there is no leak, and especially after we separate the cord. And remember that the drug is usually in resuscitation aid to adjunct oxygenation after effective ventilations. It will support the myocardium and it correct the acidosis. For example, if a patient having effective ventilation with chest compression, epinephrine can treat and help improvement of bradycardia, and it's very powerful adrenergic agonist, and works both in adult and in neonate, and it can induce intense vasoconstriction for alpha stimulant, and it can improve coronary and hence cerebral artery perfusion. The dose is extrapolated from adult study, and usually we give it IV as 0.1 or 0.3 ml per kg of 1 in 10,000 concentration of epinephrine. It can be rapidly given through umbilical vein that inserted for purpose of emergency situation, and after giving it, it can be flushed to reach the central circulation. Usually we can repeat the dose for 3 to 4 cycles, each 3 to 5 minutes, with proper ventilation and chest compression. If we don't have a central line and access to emergency UVC is not possible and intraosseous is not possible, then administration of the epinephrine through endotracheal tube is not a wrong idea, because the transpulmonary absorption is not bad. And the studies in animal confirm that this is an acceptable route of administration. This route of admin considered either when we don't have access, or we can give it during the insertion of the IV, and usually we give it somewhere between 0.5 to 1 ml per kg, or about 3 times the IV dose of 1 in 10,000 epinephrine solution. These larger doses need not to be, of course, diluted, because it can give more volume, and we know that if we give 20 ml per kg of fluid to the lung, it can induce submersion or drowning. If 2 doses of epinephrine do not produce improvement, additional doses can be given. But in that situation, if no 2 doses not improving, then searching for other causes and treating them, if it's not done already, should be done. Other medication is the volume expander. If ventilation and oxygenation, effective ventilation and oxygenation has been established, but still you have low blood pressure and there is low peripheral perfusion, a volume expander is indicated. With current practice of hemodynamics, and if baby is stable enough, use of echo can help to see if the hypotension is volume replaceable or not, using the variability of blood pressure events. But most of the time we can give 10 ml per kg of normal saline, usually is effective. If there is a history of bleeding due to, for example, apraxia placenta, higher dose may be considered, and it's better if there is a bleeding than to be replaced by the same of the fluid loss, which is the blood. There are other indications of volume expander include, in addition to acute bleeding, is the poor response to the resuscitation effort. Sometime, and as always, we have to be careful when we give medications such as volume expander in those hypotension caused by other than loss of fluid, such as asphyxiated myocardium, rather than hypovolemia due to fluid loss. It's important also to consider the gestational age and birth weight in assessing the blood pressure and using the trend rather than one number to decide the volume status. Bicarbonate, in my opinion, is a useless drug. It can be more dangerous than benefit, and it's been confirmed by many animal and even observational studies. It causes buffers during immediate resuscitation, and it might contribute to cellular acidosis, so it is not advisable. As everything in medicine, there is potential risks and benefits of all medications. And therefore, administration of these medications should be reserved and cautioned before administration for those with bradycardia that persists despite adequate oxygenation and effective ventilation after establishment of airway. If you have a doubt about the effectiveness of ventilation, endotracheal tube is indicated before starting the chest compression. Once you establish the adequate air entry and adequate effective ventilation, and the heart rate exceeds 100 beats per minute, the infant should be moved to an ICU for more stable circumstances to provide effective support. At that time, physical examination, checking the vital signs, a test might be done, such as chest radiograph or these days ultrasound, and that will help to direct the management to specific interventions. If the depression or newborn deterioration due to, for example, narcotics, reversible, although sometimes needed but rarely necessary, as the primary steps of resuscitations would be effective most of the time. But if the mother received narcotic analgesia within a few hours and the infant is not responding to the initial effective measures such as providing oxygen and effective ventilation and maybe non-invasive or invasive ventilation, then reversal of narcotic effect might be necessary in very rare situations. There are specific situations such as meconium aspiration, and if the baby are depressed and the meconium are staining the amniotic fluid, the obstetrician should quickly assess the baby during birth process for presence of secretion or copious amniotic fluid. The practice has been changed and routine suctioning of the meconium stained infant fluid is not recommended. But if there is a presence of significant amount of fluid that obstruct the upper airway, suctioning of the mouth and pharynx for a short period of time using a bulb syringe might be indicated rarely. In that situation, the newborn should be assessed to determine whether he or she is vigorous and having strong respiratory rate with good muscle tone and the heart rate more than 100. If the infant are vigorous, there is nothing specific in the situation in the presence of meconium stained fluid and should be treated as usual. However, if both the obstetrician provider and pediatric team in the caring team agreed that infant is vigorous, it's not necessary to take any actions, and most of the time the baby should be handed to the mother for skin-to-skin and further management. However, if the infant is not vigorous, then appropriate resuscitation measure should be given and should not be differ from the standard resuscitation measure. The practice has been changed from suctioning of the upper airway to not suction. But it's important to remember with the change of praxis of non-suctioning to clear the upper airway from thick secretion and open the upper airway. Now, infant with a risk of meconium aspiration who has a respiratory distress and the oxygen saturation is dropping should be monitored to see the transition, because most of the time there are some causes that might interfere with the transition. These causes led to meconium aspiration syndrome. In shock, some infant may present with pallor and signs of shock from the delivery room. And in that situation, it's important to exclude the intrapartum blood loss, such as early placental separation or fetal-maternal hemorrhage, or damage or avulsion of the umbilical cord or vasa or placenta previa, and sometimes traumatic incision during C-section or twin transfusion or rupture abdominal viscus such as liver and spleen due to difficult birth process. Or sometimes shock might be resulted from vasodilatation or loss of vascular tone because either septicemia or hypoxemia or acidosis. Usually these babies are pale, tachycardic, more than 120, tachypneic, and hypotensive with poor capillary filling and weak pulses. After starting the respiratory support, immediate transfusion. It's preferred to be blood, and if there is no time to do cross-matching O negative, packed RBCs are indicated. Till the blood are available, normal saline boluses might be necessary. A volume is 10 is advisable, but if there is a continuous bleed, 20 ml per kg is not wrong idea through umbilical catheter that is administered for emergency situation as low-level umbilical catheter. If there is no clinical improvement, and there should be a little bit of asking ourselves and examining the baby for the site of the blood loss. Because if we find a continuous blood loss, a continuous replacement might be indicated. It is vital to remember that some of the blood tests at birth might be not easy to interpret and might be normal even in shocked baby. Except in cases of very obvious large amount of blood loss, the use of blood transfusion after delivery might be not a great idea. It's always better to concentrate on the acute stabilizations, and most of that can be achieved by volume replacement such as normal saline. And it's usually the primary source of first replacement fluid. It's already available, has no much of side effect. And it can be either the sole treatment or it can be a temporary treatment to bridge the time for getting blood replacement. Most of the time, the situation can be treated and controlled by normal saline, and the need for blood is usually unnecessary. If the infant failed to respond to the first resuscitation measures include providing of oxygen and effective ventilation with chest compression and medications, consider other causes that interfere with the improvement and transition, such as air leak. Example in pneumothoraces, uni or bilateral, pneumopericardium, and it can be done either through transillumination or chest x-ray, and these days through ultrasound. The other causes after meconium aspiration, shock, blood loss, and asphyxia, prematurity might interfere with the normal transition from fetal to neonatal life. These babies need special care in 4 areas, which is the temperature, the sugar, the airway and breathing, and the circulation. So provide oxygen air mixture or blender, and monitoring oxygen is vital to have when caring premature baby. We have to be very careful of losing the sensitive walls because of the premature skin and the need to use plastic wraps or bags. Use of exothermic mattresses to prevent heat loss, and use of warmer and resuscitators and use of dry sheets are important because their skin are thin and it can increase, there is big surface areas in relation to the body, and it can cause excessive temperature loss and hypothermia. Although in addition to the temperature and ineffective respirations, premature babies are having most of the time apnea due to respiratory insufficiency. And this is more common with low gestational age, and support need to be in. So always consider to give caffeine as early as you can. These babies also having most of time surfactant deficiencies and poorly compliance alveoli, in addition to the poor compliance of the chest wall and diaphragm. And therefore, early rescue of surfactant administration is the standard of practice. Depending on the reason for premature birth, an infection, especially in spontaneous delivery, is a common cause of premature infant, and it increases the likelihood of complication perinatal depression. So a sepsis workup and starting guessing antibiotic therapies is the standard practice. One of the important tools that's been used for a long time is Apgar score. The purpose of the Apgar score is not to guide resuscitations. The resuscitation should be guided by assessment of respiration, heart rate, and killer or oxygen saturation. The Apgar score is usually assessed or scored retrogradely and by recalling the numbers, and it's used to assess and evaluate the resuscitations, and not meant to make decisions about resuscitation. It composed of 5 objective signs in newborns, and each one of these objective signs giving scores of 3 from 0 to 2. A total score of Apgar at 5 minutes after birth is usually recorded. If the Apgar score, however, at 5 minutes is 6 or less, then scoring should be continued every 5 minutes until we have a score of more than 6, and then stop. A score of 10 indicates the infant in perfect condition, and it should be rarely happen. Most of the babies, if not all of them, having some degree of, for example, acrocyanosis, and they won't have a 10. The scoring, if done properly, should yield the following information. 1 minute Apgar score usually correlate well with umbilical cord blood gas and indicate intrapartum depression. It has nothing to do with the outcomes. A score of 0 to 4 at 1 minute to have significantly lower pH, higher carbon dioxide, and lower base excess. And the score of more than 7 have a different values, and usually the scores of pH, the bicarb, and the buffering or base excess usually in more reasonable normally transitioned baby levels. In premature babies, however, the low Apgar score does not indicate severe neonatal depression. The also 1 minute Apgar score up to 5% of effect in gestation between 25 and 27 might not indicate that really the baby is in a serious condition, and it can when it becomes between 0 and 3, it might relate to a pH of more than 7.25. Therefore, in very low birth weight infant with low Apgar score, we cannot assume that he or she is severely depressed with low Apgar score. Despite that, most of these infants resuscitate actively and usually respond promptly and with less invasive measures than those with low Apgar score at term infant. Apgar score after 1 minute, it more reflects the postnatal period and the response to adequate and effective resuscitations. If the Apgar score persistently low, it indicates a further therapeutic measure should be taken, and usually the severity of baby underlying problem are continued. It can be used in assessing the adequacy of resuscitation. Most of the time, these low Apgar score indicate inadequate pulmonary inflation and ineffective ventilation. It's important to verify a good seal of mask or correct placement of ETT and giving adequate volume expansion and PIP, adequate PIP and adequate PEEP through a bag and mask when these Apgar score fail to improve. A more prolonged period of severe depression, that's why Apgar score of 3, that more likely is abnormal, Apgar score at 10 minutes and 15 minutes, and the Apgar score is 3 or less, then it's mostly of prognostic value, and it can predict the long-term unfavorable neurological outcome. Sometimes babies with more prolonged depression, more than 15 minutes, they can have a favorable outcome. To take it further, cerebral palsy is not commonly associated with a prolonged period of neonatal resuscitations and low Apgar score at 10 and 15 minutes. The Apgar score, designed to monitor neonatal transition and effectiveness of resuscitation, and their utility remain essentially limited to that role as a value to review the effectiveness of resuscitation, and is not meant to make decisions during resuscitation. Apgar score were designed. Apgar score somewhat designed in a way that it is very subjective, especially in a premature baby. And there is now a talk about recommending an expanded Apgar score report, where to give more detailed numeric score and associate it or link it with the concurrent resuscitative interventions. The practice of resuscitation will continue to improve and change when new devices are discovered and we're more understanding of the transition period and best approach, and with more evidence occurring. Some of the tools such as End-tidal or expiratory detectors are in use, and it's already been used for a long time. It's confirmed the AT2 placement. These are either calorimetric or capnography. Especially it have a utility in bag and mask ventilation in helping identifying the airway obstruction. It can help to decide appropriate ventilation being offered, or in assess the adequacy of spontaneous circulation too. The other change of practice is in detection of therapeutic hypothermia in babies who are depressed and they are more than or they are 37 weeks and above 37 weeks of gestation. Most of the practices globally accepted that therapeutic hypothermia should start within 6 hours of birth. It's not known that whether earlier initiation within 6 hours increase the effectiveness or from the late initiation. More mildly affected infant may benefit from this therapy under certain circumstances, but this remains under study, and it needs time to be approved, as most of the resuscitation used for moderate depression rather than mild ones. When we start therapeutic hypothermia, the role of passive cooling also required a more complete evaluation. However, in my opinion, whether it's passive or active, it's the matter of keeping the temperature somewhere around 33.5 degrees Celsius. Avoidance of maternal or neonatal hyperthermia is warranted and may prevent subtle neurological injury. When to withhold the resuscitation? Most of the resuscitation should be provided as the likelihood and the chance of survival is high, more than 24-weeker. Most of the center also provide for 24-weekers, and there's a good percentage of centers provide the resuscitations for 23-weeker. Therefore, in those situations where the survival is unlikely or associated with high morbidity and bad outcome, the wishes of the parent as the best advocate for their baby should be respected on decision to initiate resuscitations. If there is no signs of life after 10 minutes of aggressive resuscitation, which means effective ventilation, chest compression, and medication, and there is no evidence of other correctable causes that compromise the newborn, a reasonable decision is to stop resuscitation at the age of 10 minutes. In each case, the decision to stop should be individualized. Effective ventilation, chest compression, providence of in, and absence of preventable causes. It's also appropriate to assess the availability of advanced intensive care, including therapeutic hypothermia, baby's gestational age, and specific circumstances prior to birth, and assess the presumed etiology and timing of perinatal events. And if we have this information, the decision to withhold or withdraw the resuscitation can be more confirmed on good ground. It's always desirable to understand the wishes of the parent under the circumstances prenatally if possible. And by this, I conclude the resuscitations, the early step after birth. Thank you for watching this, and I hope I see you with new videos. Thank you very much.